A very warm welcome to today's talk. It is Wednesday the 10th of March, and for me personally it's 20 days after my first vaccination. I'm going to start off with some fairly good news from Mousy Brown from the United States this morning, just a communication. So he says a big change in Louisiana. All at once, the Janssen Johnson & Johnson vaccine is available everywhere. Community centres, vaccination centres, doctors' offices. I couldn't get scheduled for another, but could have my choice of place where I got the Johnson & Johnson. So that's all good news. And he thinks that's attributable to improved logistics, which is probably part of it, of course, because you don't need the super cold chain, and you can just leave it in the vaccine overnight, leave the vaccine in the fridge overnight, then just come back and start vaccinating from where you left off yesterday. So sounds good. Let's hope that's happening everywhere. Now, I know the vaccine rollout in the States is a bit patchy, but Alaska is now offering immunisations to anyone over the age of 16 who lives or works in the States. No appointments, apparently just turn up. So they're not scheduling older people or younger people or people at risk, just anyone can turn up. So let's, so first test case state really in the United States. Let's hope, there's no reason why we shouldn't get vaccination figures well into the 90s there within a week or two. And pretty well 100% hopefully by a month or so. So we'll keep an eye on that as long as the information becomes available. Now, in the United States, in the past 7 days, 2.1 million doses per day. Now, what do we think of this? I think it's absolutely spectacular. So they'd hope for 100 million doses in the president's first 100 days. The daily rate is double that. This is remarkably encouraging news. And to be fair, I did anticipate it. When the United States gets going, it can get going. It has that capacity. So really good news. And we'll just look at the daily cases in the States there at the moment. We see they're down, kind of levelled off. But we're still at a reasonably high rate. I mean, the average there is 68,000, 7-day moving average. So the big problem, the big risk in the States now is cases are coming down, vaccinations are going up. The big risk is complacency. And of course, today, Texas liberalises its regulations quite significantly, for example. And then we've got holidays coming up where everyone could be piling down to Florida. So we're not quite there yet. And there still is the real risk and indeed the probability of increasing cases in the States. But first, FIRST, that's spelled wrong. First dose of vaccine, 61 million. Second dose of vaccine, 32 million. So the vaccination programme, I must say, I'm pretty impressed. And we've looked at that. Now, the deaths in the States, unfortunately, have come down remarkably slowly. So still pretty high there. These are daily figures of what? Just under 2,000 daily deaths, about 1,800 daily deaths a day. That's the 2,000 line there. So it's still an issue, and as I say, complacency is probably the biggest risk to the United States at the moment. Now, on those lines, Professor Chris Whitty, the UK Chief Medical Officer, unlocking too quickly, talking to the MPs. There's some MPs who want to get going, of course, and that's quite understandable. But Chris Whitty is saying, unlocking too quickly, substantial surge, while a lot of people are not protected. So Professor Whitty seems to have got the hang of this now. Now, at the start of the pandemic, as I recall, he was advocating a herd immunity strategy. So he's changed his tune and is now advocating caution, which I must say I agree with. I was advocating caution back in the early part of last year. What's confusing me, though, is why the Chief Medical Officer thought we could have as I understand this, why he thought we could have a herd immunity strategy in the first place. I mean, you'd expect the rest of us to learn as we go along, but you would have thought the people that are already in post would already know this. It's one of these strange things about the pandemic, the ignorance of infectious diseases in people that should have known about it. Quite stunning. Anyway, I'm very pleased to see he's giving this note of caution now. A lot of people may think this is all over. They think it's all over. It isn't yet, would be the English cultural paraphrase. It's not over yet. Or in the States for that matter. It's very easy to forget how quickly things can turn bad. Direct quote from Professor Whitty again, which of course I agree with. 3 weeks to build up immunity from the earliest vaccine. So I'm on 20 days now. 21 days tomorrow from the first dose. But of course in the UK that doesn't yet change our behaviour. We are still governed by national guidelines as opposed to the United States, which has gone for the more individualised approach for people that are vaccinated, as we talked about yesterday. So only the first 4 priority groups, the over 70s, healthcare staff and the extremely clinical vulnerable, have had time for the vaccine to build up. I was lucky, I got mine early because there was some left over, but we have this 3-week gap. And while I'm talking about that, I must say the official guidelines we looked at yesterday, and indeed looked at again today, are saying that people basically can consider themselves immune from the US guidelines after 2 weeks after the Johnson & Johnson vaccine. I don't think that's half the time needed. I haven't got the full data, but I would be really surprised if you had full immunity at 2 weeks. I would be staggered if that's the case. So I'm expecting the United States authorities to change their guidelines to make that 4 weeks after the first Johnson & Johnson Janssen vaccine soon, because I don't think I don't know of the data that supports that 2-week contention. So I expect they'll change that. So basically, there's this lag effect, and the immunity is not there for everyone yet. Nearly half of the hospital admissions have been in the under 70s, so this is the group that's now at risk, while we wait for their vaccine immunity to build up, and while more are vaccinated. Most transmission driven by younger people. Now, what this means is, and again, I agree with this, especially because schools have gone back. In the UK, we are going to see an increase in cases. I don't think there's any question about that. We're going to see an increase in cases. But because the most vulnerable people who are most likely to die have been vaccinated, the cases will go up, but the deaths shouldn't. The deaths that are going to increase are in the not yet vaccinated group, the under 50s, the under 60s. They're going to be the at-risk group next. And if we actually look at the vaccination situation in the UK, the numbers are good, the numbers are coming on. But of course, the interesting thing is, this is the first dose graph. Can I move that? Yes. This is the first dose graph. And we actually see the numbers are going down slightly, the number of people getting the first dose, even though the vaccine supply is the same, because of course it's now within the 3 months and we haven't start vaccinating, giving people their second dose. So obviously this is using up a lot of vaccine supplies. So while the cumulative numbers are increasing, obviously, the actual daily numbers are down somewhat in terms of first dose. But of course, this strategy has bought us this essential few-month period. Now, I've been criticised for saying the UK has got a one-dose strategy. Of course, it hasn't. And the people that have criticised me for that are quite right. I apologise. It's not a one-dose strategy. Most certainly not. It's a primer dose followed by a longer delay to the booster dose. Probably 11 or 12-week delay to the booster dose. So it's a delayed second vaccine strategy. So the people that have correctly picked me up on that, my apologies for being sloppy. We'll try and get that. Right in future. Now, where are we at? So cases could go up, but deaths hopefully will not. But bear in mind, this vaccine's taking time to work. Therefore, UK strategies will not impact spread for a while yet. So this could go on spreading for a while yet, is kind of the bottom line of Professor Whitty's statement there. Now in the UK, these were the cases today. So another 5,766 cases in the past 24 hours. This is probably a better guide. 40,600 cases in the past 7 days. 7-day figure down 24.5%. 1,329 deaths in the past 7 days, down 33.2%. I mean, we're still talking about 231 deaths in a 24-hour period. It's not gone away, but the direction's good. Hospital admissions, likewise, still quite a few. 5,000 people admitted over the past 7 days. 590 yesterday, but that's still down 29%. And hospitalisations as of yesterday, were 9,418, first time below 10,000 since the 25th of October. So that is That's good. They're encouraging reductions, but as I say, we will see an increase in cases, I think, inevitably, with schools going back and this roadmap to normalisations. But hopefully not the pressure on hospital and not the pressures on death, not the increase in deaths. But I am concerned for the still vulnerable but not yet vaccinated group and the still vulnerable vaccinated group while we are waiting for the immunity to develop. So there we go, vaccinated numbers. And my apologies, UK is not using a one-dose strategy. I can't remember who was my main critic on that, but I appreciate the feedback. It's using a booster followed by a delay. So it's using a primer dose followed by a delay to the booster dose. Now, next thing I want to do is comparisons between the Pfizer and the Oxford AstraZeneca vaccine in the UK. Now, this data came out on the 8th of March. It's from the COVID Symptom Tracker app, and the number involved is over 700,000. Of course, I'm one of them. And people that have had the injections log in, 700,000 of them now, daily health reports. So the Pfizer vaccine came out first, of course, so that was the first one to collect data on. But data is starting to come through on the Oxford AstraZeneca vaccine now as well. Both bodies cause the body cells to produce the required antigen. So as you know, the Pfizer vaccine gives a bit of RNA that codes for the spike protein. The Oxford vaccine gives some DNA in the adenovirus vector, which transcribes, I think, into, I can't remember, I've got them mixed up, transcribes into RNA in the cytoplasm and produces the protein. Anyway, the end result is that a bit of the spike protein gets produced by both of them. Not the whole virus, that's the antigen, that's what the immune system recognises as being foreign. So the RNA and the DNA both resulting in the RNA producing this particular protein shape, which is the antigen the immune system recognises as being foreign. Both vaccines induce really high levels of antibodies and T cells. This is a direct quote from the article. I know it's not very scientific, but it gets the message across. Consistent with the phase 3 data. So this is good. In terms of vaccine rollout, we're not really seeing any particular surprises that we didn't anticipate from the phase 3 clinical trial data, indicating how good that data has been, how well conducted the trials were. Tim Spector was seeing around 70% reduction in mild disease after the vaccine, because this is after the first dose. It's what we would expect, and it's really good news. But we know we see greater efficacy against more severe disease, hospitalisation and death, although this report doesn't specify that. So side effects, common ones are tiredness, headache and chills. Chills indicates that you feel cold because the body temperature is going up, getting a bit of a low-grade fever or low-grade pyrexia. Now, after the first dose of the Oxford AstraZeneca vaccine, 30% get side effects that are worth reporting, not side effects, after effects. The Pfizer vaccine, it's only 10%. So on that, it looks like you're probably better getting the Pfizer vaccine in terms of side effects than the after effects, compared to the Oxford AstraZeneca. But the data coming through seems to be showing that the side effects after the second dose of the Pfizer are worse than the Oxford. So it looks like with the Oxford vaccine, you've got an increased risk of getting side effects after the first dose. And with the Pfizer vaccine, you've got an increased risk of getting side effects or after effects after the second dose. So maybe this kind of balances out. And at the moment, the aim is, in fact, I think this is being done all the time now. Whatever vaccine you had for the first dose, that's the one you're getting for the booster dose. That'll probably change. The mix and match strategy will probably come in, but we're waiting for data on that. So I suppose that would mean that ideally you'd have the Pfizer for your first dose and the Oxford for your second to minimise the after effects, but there's no data on that, so we can't say. But the people I've talked to, personally, I was fine after the Pfizer. Most people I've talked to have been. People sometimes do get effects for 24, not more than 48 hours. I was talking to one person who had the infection themselves, quite a bad case of the infection, back in the end part of last year, and they had the Oxford, and they were a bit ill for 4 days, but they'd already had it. But typically it's 24 or 48 hours of feeling not so good, which is a price, in my view, well worth paying for the immunity that you get. So Pfizer systemic side effects worse if people have had the COVID infection before, of course. In fact, that's true for both of them. It's just that the data's not fully there yet on the Oxford. Pfizer side effects worse after the second dose. After effects seen less than phase 3 data. So this is slightly better than the phase 3 data, which is good. Now, this was interesting that the people who wrote this said, can't associate measured immune response with protection. So if you measure the antibodies and your antibodies are low, that means you may have a high level of protection. Or if you measure the antibodies and the antibodies are high, that doesn't necessarily mean you've got a good level of protection. So in other words, with lab tests, it's very hard to measure the level of immunity that's generated. So the antibody responses aren't highly correlated with the amount of immunity that's generated. So it means it's pretty hard to monitor, really. What's actually the real monitoring effect is how many people actually get the infection, how many get sick. And of course, we know that they are nicely down. Females, younger people, and those who have had previous COVID infection, more likely to report after effects of the vaccine. And I think we've known that for some time. And now this was interesting. Now, I have thought that people that get more severe after effects from the vaccine are getting a greater inflammatory immunological response, therefore are probably generating a high level of immunity. But it looks like this is not the case. So the COVID Symptom Tracker Act data is saying that how unwell you feel after your vaccination is not related to the immunity generated. So it looks like my idea there has been reversed or countermanded, at least, by ongoing data. So the current view of the COVID Symptom Tracker app data and the people interpreting this data are that people that have minimal after effects might have good immunity. People who have a lot of after effects don't necessarily have better or worse immunity. It doesn't seem to be related. Now, the next story is, I hesitated to run this one, but it's interesting, so I'm going to go straight into it. This is from the Food and Drug Administration in the States. And of course, I looked at this because we want to completely agree with this. Why you should not use ivermectin to treat or prevent COVID-19, because the reason we agree with this is people have been taking medicines that for horses and things like that. So that's obviously the case. Taking a non-prescribed medication that's not been prescribed for you by your own healthcare provider is always a dangerous thing to do, and nothing we would ever advocate on this channel. But people, it seems, have been taking veterinary doses of ivermectin and getting side effects. But what caught me here, what caught my attention here, is this paragraph here all seems quite reasonable. And then the FDA say ivermectin is not antiviral. It's not an antiviral. And then in case we don't know what antiviral is, they spell it out, a drug for treating viruses. So here we have the FDA making a statement. So we reinforce that we agree with the argument they're trying to make. We agree with the argument they're trying to make that we shouldn't be taking horse medicine, even if the active ingredient's the same. But then they state here, ivermectin is not an antiviral. Ivermectin is not an antiviral. So that's like a definitive statement. So that kind of caught my attention, really. So this is from the FDA, Food and Drug Administration. All this sort of stuff, official website, here's how you know. So the FDA has received multiple reports of patients who've required medical support and have been hospitalised after self-administration with ivermectin intended for horses. So really bad idea. I'm upset that people are doing that. But then they say ivermectin is not an antiviral. So here they've made a statement. So what we want to do is, I don't think I'm allowed to disagree with official bodies. So what I'm going to do is I'm going to report from Nature Portfolio, Journal of Antibiotics. And this is the study here, which of course you can peruse for yourself. Systematic review from antiviral effects. Right. So here is that. Here's that paper. There's the abstract, and then there's all the details. But I'm going to pick out some of the interesting bits. Now, remember that FDA statement. Ivermectin is not an antiviral. So journal Nature portfolio doesn't get a lot better than that, really. And here's some things from that. Ivermectin, a systematic review from antiviral effects to COVID-19 complementary regime. So, right, direct quote from that article. Ivermectin possesses many properties, potential effects to treat a range of diseases. Okay, interesting, but doesn't tell us too much. But then it goes on to say it has antimicrobial and antiviral effects. So it's clearly saying it has antiviral effects. Whereas the statement clearly said, well, it doesn't know, it's not an antiviral. That's the FDA statement, it's not an antiviral. Another direct quote from this article, it's highly effective against many microorganisms, including some viruses. So Nature and this journal of antibiotics is saying it is effective against some viruses. In this comprehensive systematic review, antiviral effects of ivermectin are summarised. So not only is it saying it does have antiviral effects, it's going to summarise them for us, which of course is nice, including in vitro and in vivo, so in glass, in life studies over the past 50 years. And it goes on to talk about several studies report antiviral effects for ivermectin on RNA viruses such as Zika, dengue, yellow fever, West Nile, Hendra, Newcastle, Venezuelan equine encephalitis, which I assume is a horse infection. And yeah, I could go on. There's different human and animal infections there. Several studies report antiviral effects of ivermectin. So this is saying several studies report antiviral effects of ivermectin, whereas the FDA is saying it's not an antiviral. Why would they say that? Why would they say that? On their website, it seems strange that they would say that, because this seems to be conflicting evidence. Still from the same review paper, furthermore, there is some studies showing antiviral effects of ivermectin against some DNA, deoxyribonucleic acid viruses, such as equine herpes type 1, which I assume is a horse virus. Doesn't matter what the viruses are, but there's some clearly veterinary antiviral effects there. In vivo studies of animal models revealed a broad range of antiviral effects of ivermectin. So the scientific literature is saying it has a broad range of antiviral effects, and the FDA has stated ivermectin is not an antiviral. Now, I just wanted to point out that contradiction, really, and I'll put a few references in the without going through them all, I'll put a few references in the linkage for you at the bottom. Now, there's a few more there, look. Now, you're limited as to how many references, how many stuff you can put in the description on YouTube videos, but I could have given many more references. So, just to recap that, very important that we agree that you follow the guidelines here from the FDA. Of course, you have to follow your national guidelines wherever you live. So very important to follow the guidelines, but it just seems strange to me they've made that statement, that ivermectin is not antiviral, whereas other literature indicates that it does have antiviral properties. So, strange. Right, Germany, just to finish off with, I'm just really, it's a bit upsetting, really, to see how low, when we look at the vaccination rollout in the UK and the States, the European situation is just not good. So apparently family doctors in Germany will be allowed to administer the vaccine from April. I was taken aback. I taught first and second year student nurses how to give injections. The idea that doctors have not been allowed to give the vaccine up till now. But big news that from April they'll be allowed to give it when I teach junior student nurses how to do deltoid injections. Strange. Lots of doctors have been doing it in the UK for ages. Mind you, I think they're paid about £12, or the surgeries are paid about £12 a vaccine, so there's a bit of an incentive there, to be fair. But that just struck me. They're going to be allowed from April, as if this is some kind of big deal. 3% currently fully vaccinated in Germany since late December. AstraZeneca, which had been sitting in fridges doing nothing, is now being rolled out to the over 65. So some good news there. And then just this one was interesting. Vaccinations Committee seemed to be supporting the Sputnik vaccine. Now, the European Union officials warned against it, saying not rush into it. And here we have the Germans saying they're actively considering it. And what we believe is happening is there's a rolling review of data by the German Vaccination Committee from the rollout in Czech Republic, Hungary and Slovakia of the Sputnik vaccine. So it looks like Germany is probably going to approve that at some point. Right, well, a bit of a varied talk today, but just contradictions annoy me, so that's why I did it. Now, are we going to see any pictures? Yes, we are, albeit with a delay. Of course, your pictures are brilliant. This is Carolyn, who's in Oregon, who's been watching for quite some time. So, Carolyn, it is really good to see you're watching, and thank you for sending that in. And you've got a few of your bits and bobs there, so and I'm glad to see that as of today you are looking very healthy. So that's thank you for watching. Thank you for sending that in. Yeah, you know, if you're young, you don't appreciate the internet. It just blows my mind that people can be watching this in different countries. You know, the internet wasn't admitted when I was invented when I was young. I just find it incredible. If you're young, you probably just take it for granted. But you know, the idea that Carolyn is watching in Oregon, I think it's just amazing. And this is Rich. And I think this tells you everything you need. Rich from Bloomsbury, jabbed by pharmacist Aniti in North London. So congratulations to pharmacist and to Rich. And Rich is being vaccinated before his age group for very good reasons. So great picture of both of you, actually. So appreciate that, and delighted that you're getting the coverage, Rich, and thank you both for sending that picture in. So deltoid injection is not a problem. Doctors can do it, pharmacists can do it, student nurses. I've trained hundreds of them to do it, and it really shouldn't be a problem. Okay, that is us for today. Thank you for watching, of course.